at the beginning of the month of May, Jean Dubousset, here is picture, and it's very important it was very important for us, the French school. The first work of Jean Dubousset, he was passionate with the 3D reconstruction, and for him, X-ray, the frontal X-ray, at this time it was quite only the frontal X-ray to treat scoliosis, this 50 years ago. He says always that it was a shadow of the 3D reality. And he tried, his first work was 78, was to try to have a reconstruction, a 3D reconstruction. And at this time, the first publication was on infantile scoliosis. And naturally, before there was the sensation of the horizontal plane. The horizontal plane was important. You remember the work of Adams. There are many works, but we don't see really the horizontal plane on the X-ray. And with the 3D reconstruction, it was one of the first 3D reconstruction, we see this horizontal plane. And I show you this slide because since this time, the horizontal plane was used at prognosis for infantile scoliosis. Infantile scoliosis, you see this, I must change this, okay. You see this 3D reconstruction of resolving scoliosis with no rotation, a curve, frontal curve, but no rotation. And if we choose the limit of the vertebrae, you see that you don't have in the same plane, oblique plane, you don't have the limit vertebrae and the apical vertebra. The progressive curve was a curve with important apical rotation. So the horizontal plane makes the difference between resolving and progressive scoliosis. And we see also the evolution with malignant progressive scoliosis, scoliosis of more than 60, 70 degrees. For infantile scoliosis, you see together rotation, important rotation at the apical vertebrae, but also you have in the same oblique plane, you have the limit vertebrae and the apical vertebra. So since this time, we have the feeling, Jean Dubousset and all the French school have the feeling that it was the horizontal plane was very important for prognosis of scoliosis, evolution of scoliosis. Also naturally for treatment, but for the evolution. And you say it's a slide of Jean Dubousset. He presented this at the meeting, SRS meeting in Chicago, 1980, but no one understand the horizontal plane. It was only, we work at this time, we work only, the surgeons, especially the surgeons, are only working in the frontal plane. So you see that with the infantile scoliosis and the 3D reconstruction, we have differences between resolving scoliosis, progressive, and malignant scoliosis. Then the idea was to try with X-ray to represent really with X-ray the horizontal plane, the 3D reconstruction to facilitate the 3D reconstruction with the principle of Sharpak. It's the multi-wise chamber. It was work with Nobel Prize in 68. The Nobel Prize was 92, but the work was 68. And we use this principle to have a diminution of irradiation, X-ray irradiation. At the beginning, it was 10 times radiation less, and today we are at 25 times diminution of radiation. So this was very important, and the most important thing is that we have together the frontal and the sagittal X-ray, so we have a real reconstruction, 3D reconstruction. If we use first the frontal X-ray, then the lateral X-ray, it's not exactly the same positioning of the patient, and the 3D reconstruction is possible. This is what we do before EOS, but we don't have exactly the same position in the frontal and the sagittal plane. With this system, we have less radiation, and we have together the frontal and the sagittal plane. And the other important thing is that we have a total body imaging system. So we have also the lower limbs on the X-ray. So uh, we can integrate in the vertebral deviation and the deviation of the lower limbs. Very important for adult patients. We will see after that we have a pelvic retroversion, so we can calculate the flexum of the femoral flexion. And we have a lot of more information for our patient. Then after have this software of 3D reconstruction and the EOS system, simultaneous frontal and sagittal plane, we have many information with detorsion, the concept of detorsion. With the first detorsion brace, it was a 3D brace, a severity index, a rotatory dislocation, and penetration index for very malignant scoliosis. So the motto, no matter the etiology, scoliosis is always a deformity in the horizontal plane, is true, because if we don't have rotation in the horizontal plane at the apical vertebra, we don't have really a scoliosis. So this is very important, and you see the 3D reconstruction with the total body, and we can control the pelvic rotation at uh, the hip level, at the knee, and also at the foot. This was the integration. At this time, the plaster cast was done with a lot of extension of translation along the z-axis. And after the work of Dubousset, and we do the same in Lyon, quite the same in Lyon, we work more on the, we can say, the mechanical detorsion than the geometrical detortion. So this was the concept of detortion at this time, very important, and it's the same for the hard brace. Hard brace is detorsion brace. And historically, you remember, I show you this slide, the work of Lewis Serre with a geometrical detortion and the horizontal rotation when you push on the rod of the copper rod, you have the rotation automatically, and if you pull on the rod, you correct scoliosis. So the concept to slide from derotation to detorsion is a consequence of this work of 3D representation and the work on the EOS system. So you have here the first detorsion brace of Dubousset. This brace was a little difficult to construct, to design, and the problem is that it works with bracing, and with all this type of brace, working with bracing, we lose energy with bracing. So to use the corrective forces of bracing when you have the respiration, bracing, it's not very useful. You lose some energy. So this is why the hard brace is a little different. And we have also for mild idiopathic scoliosis, we can define a torsion severity index because we have the exact rotation at all levels, both at the apical level, but also at the limit vertebrae, at the extremity of the curve, and in fact, we can measure the exact rotation on all vertebrae inside the curve. And we can define this index, an index of rotation. And with less rotation, we have stability, more stability. And with more rotation, we have progressive scoliosis. So we can have a classification with the horizontal plane. Alors, it's very important, this work, because the idea is not to lose time before the beginning of the treatment. And if it's possible with angulation between 10 and 20 degrees to have a selection of scoliosis, we can begin the treatment, physiotherapy between 10 and 20 degrees and bracing after 20 degrees. We can begin at the good moment, and this not only with the curb angle, but also with rotation. So you see this curve, we don't have a lot of curb angle, 12 degrees is not very important, but you see the important rotation at this level, L2, L1, and also all vertebrae inside the curve. And you see the evolution in 20 to 25 degrees, sometimes in 6 months. 6 months after, and the idea is not to wait too much but why not begin physiotherapy at this moment when we see rotation on the X-ray? Voilà, it is necessary to treat with a brace. We have also for adult patients, it's the same. We have the main complication of adult scoliosis is the rotatory dislocation. And sometimes we can see this rotatory dislocation here between L3, L4. We have quite no rotation at L4, and L3 we have rotation. And you see that sometimes 1 year after, we have this progression, important progression of rotatory dislocation at this level. So it's the same. We must look not only at the apical vertebra, rotation at the apical vertebra, it's interesting, but also at the limit vertebrae and see if for adult patient, we don't have a beginning of rotatory dislocation. So you see this evolution, rotatory dislocation. What is also interesting with EOS is the rib cage. You know that under T10, we work only on the vertebral body and the intervertebral disc, but between T2 and T10, we work, especially with physiotherapy and bracing, we work on the rib cage. So we can modify the positioning of the vertebral body through an action on the ribs. And it's possible to represent the ribs, and I use this with contour of the ribs, concavity and convexity, to brace, because it's not exactly the same. With the same deviation, you can have a perfectly symmetric rib cage and asymmetric rib cage. So, sorry, it's important to brace, to control the positioning of the concavity of the ribs on the concavity and the convexity. The work of Dubousset was also for surgical curves. It was a very famous surgeon with the Cotrel-Dubousset. You know this type of surgery. It was the first 3D surgery. And it was possible for scoliotic curves necessitating surgery to differentiate the penetration, the spinal penetration index. And this was very important, especially at this time for surgery. I don't insist because it's more for surgery. And you see the representation of the contour of the thorax and the lungs. This you remember with the Schrott, you have at this time, the beginning of the Schrott, the original Schrott, the curves were very important, and many patients have important index penetration. So the breathing oriented towards the concavity was very important at this time. And for scoliosis more than 60, 70 degrees, it's not exactly the same physiotherapy. Also with bracing, I say we use flexion For the thoracic curve, this increase the length of the concavity with the Lion method. So you have some representation, and under the brace, you can calculate, you can see how the volume, the rib cage volume is working. Its thorax detorsion is better, not perfect under this brace. And this is a very important concept, especially, as I say, for thoracic curve, naturally, curve upper T10. You see some representation with the top view without brace and with brace. The work was also on the sagittal plane. And what is interesting is we say usually that the pelvic incidence don't change during growth. It's a constitutional factor. This is true for patients without scoliosis. But with scoliosis, we have some change during growth. You see in this work published in 2006, you have 11 patients without change of pelvic incidence, 6 with decreased pelvic incidence, and 4 increased. And this change is correlate with the evolution, the compensation. For adult patients, you have compensation on the lower limbs. For adolescent patients during growth, the compensation is important at the pelvis level. So you have this change. And this means that for half of the patient, you have a modification of pelvic incidence, and together frontal curve and sagittal curve. There is an evolution, and this is a compensation, automatic compensation. So it's interesting to control also systematically for your patient the pelvic incidence, frontal plane, you measure the Cobb angle, and you control during growth the evolution of the pelvic incidence. And all the work of the main work for pelvic incidence was done by Duval-Beaupère, Ginette Duval-Beaupère. You have here Cotrel and Ginette Duval-Beaupère, and all this team, the team of Paris team, was one of the main elements of the French school of scoliosis. We were very close with this concept, and you will see on the other slides that many concepts you learn with the Lion method were developed simultaneously by the Paris team with Jean Dubousset. Alignment, balance, and harmony, very important. This stability. Balance is static. You have the alignment, but is static, and balance is more dynamic. And the work of Dubousset was on the cephalic vertebra, yes, but mainly also on the pelvic vertebra. With this cone of economy, it was one of the first publication, 1975. of this cone of economy for very important scoliosis. It was scoliosis of more than 60, 70 degrees. And it was possible to quantify this cone of economy with this registration on the head. The same work was done in Italy. And you see that you can calculate with the mobilization of the head. We have two elements. We can calibrate the cone of economy, and you see also that this registration is chaotic. It's a chaotic registration. You have the concept of the inverted pendulum. We will see a slide after. And this is a chaotic registration of the cone of economy. So the concept of the reverse pendulum. And Jean Dubousset don't develop too much this chaotic situation, and we discuss a lot with him. But I do the work for chaotic scoliosis under 20 degrees. But Jean Dubousset was very close to me, and he say yes, it's very important this aspect. You have a cone of economy, the chain of balance with a reverse pendulum. And one also very important concept is that on the X-ray, we see the bone, the intervertebral disc, but we don't see the soft tissue. And for Jean Dubousset, the soft tissue were very, very important. Masses are balanced thanks to the power of the muscles. So it's why there is a module on the EOS system to have a representation of this volume with also the possibility to calculate the density. Mass, you calculate the mass and the volume and density, and the barycenter. Duval-Beaupère, Ginette Duval-Beaupère work a lot with the barycenter. You can calculate for each vertebra exactly where is the barycenter. The volume and the mass, upper T3, T4, T5, T6, and we can have a curve of the barycenters of all vertebrae. It's also work they done very interesting. So the barycenter is different for the patient, and you can calculate with the EOS system exactly the mass of the patient, of the body segments. So the research of harmony is a mix of static and dynamic conditions, and harmony is very important. This is the cone of balance, the compensation. It's important harmony because you can have scoliosis very harmonious and scoliosis very disharmonious. And it's not exactly the same treatment, both for physiotherapy and bracing. You are here for, in the sagittal plane, the compensation with not a change for the same patient of pelvic incidence. Change of pelvic incidence is only during growth, but you have the pelvic retroversion and the compensation with hip flexion to recover balance. And Jean Dubousset work also for this adult degenerative patient on the cognitive aspect, major importance, and you know this during gait, you can calculate the frontal perfusion, and you see that the double task, and it's, I say always that after 55, 60 years, you work the same exercise but with dual task, and you see backward counting, you have a better perfusion, frontal perfusion. So there is a difference in forward counting and backward counting. And this is important for the extrapyramidal system to have a good vascularization, both at the head, at the brain, but also for the type 1 muscle fibers. So this is important, this perfusion. Harmony, so the sister of economy, both static and dynamic. And you see, this is the concept of the chaotic dimension. You remember the chaotic dimension. We work a lot with the Fibonacci sequence, and it's exactly the same concept of harmony, static and dynamic during the movement, during the motion. Even a spinal deformity can be harmonious. So a double curve is more stable in adult life than a single curve. For harmony of the spine, you need a 3D smooth alignment according to weight 8, acceptable arrangement of the successive masses of the body, a 3D static balance, a 3D motion, also with, it was a gold standard. We are far from the gold standard Cobb angle. It's the gold number more than the gold standard, the Cobb angle. And this is why to have this harmony, to work also on this rib cage, on the trunk. This is why in the hard brace we have a global work with these two hemivalves, and this is to have together harmony of the spine, but also at the trunk level, including shoulders and pelvis. This is this research of harmony. So then we have growth and maturation, the soft tissue. We said before, we see on the X-ray hard tissue, but we have the soft tissue with tensegrity. So Jean Dubousset was okay with the concept of tensegrity. And you remember, second evidence, the erect posture is necessary. He works a lot, Jean Dubousset, with Mashida in Japan, with chicken and also with the mouse. And quadrupedal mouse don't have scoliosis, the same privation of melatonin. And you see, if the mouse is bipedal mouse, you have the development of scoliosis. So the erect posture. This concept is together with this cone of economy, the alignment, the vertical work, and this is also why uh, it's only the clap method was in quadrupedic position, but usually we work with physiotherapy in the standing posture uh, against gravity. So soft tissue, we don't know a lot about soft tissue with scoliosis. You will see after in the second part of today, we have some publication of so sort with working on soft tissue. But at this time, till now, we don't know a lot. We work also with what is showing with the X-ray with the bone. And Jean Dubousset, we work a lot with him with this concept of fascia and tensegrity, with a different difference with ligaments and fascia. You remember fascia, you have viscoplasticity. At the end of physiotherapy, you don't have exactly the same positioning, especially in the sagittal plane. And if you work only on ligaments, especially in the frontal plane, we have viscoelasticity. So this is very important, and this function is energy restitution, or the dynamic aspect of restitution of energy. And Dubousset was also we work together with the concept of tensegrity. Uh, he, he works also on muscle function. That is very important because the muscle is both together a string and a balloon. You have a balloon of function, stability, and mobility. So this was very important, and also even if we don't develop the concept of SSOL, you remember the asymmetrical structure at L4 level, but it's exactly the same. Uh, he works also on the maturation of the extrapyramidal system, descending at the beginning, then ascending till 6 years, descending 7, 8 years. You remember maturity of the head, and both descending, ascending between 8 and 13 years. This is the concept basis of the Lion method is based on this extrapyramidal system, the maturation, progressive maturation of the extrapyramidal system. And you remember at 12 years, you have the maturation of at the spine level. And to conclude this work, this tribute to Jean Dubousset, to the French school, as conclusion, the last slide is the concept of spinal engine, 3D, 4D space and time, with including all the elements of this work: anatomy, hard tissue, soft tissue, imaging, biomechanics. And the idea is that we must work together on the spine, on all the harmony, the cone of economy, the harmony. And this is what we do with physiotherapy and bracing, not all braces, but the hard brace work on this. And surgery work only on the spine and not, naturally, not on all these elements very important for the scoliosis. I think it's the end.
Thank you very much for this tribute